I don't know. Oh, here it is.
Right, I'm going to just say a couple of words to open.
Yeah, of course.
And then Jenny will introduce you.
Perfect.
Jenny will do the introductions for the moment.
Shall I sit down while she's doing that so I'm out of the way?
Yes.
Or do you want us
Sit
over
down.
there?
Sorry, there's not many here. Presumably there are a number online. I suspect they will come in, although we were going to say once this talk has started they can't come in.
Yeah.
But what we'll try and do is maybe get them to come in.
Yeah, trickle through the back door.
My name's Susie Lamont and I'm one of the members of the Valley Road Surgery Patient Group. And we decided late last year that it would be a nice idea to have some talks for patients at our surgeries. And we then got to the stage of saying, well, what topics do we want to discuss? So one of our members came up with the idea of having a survey, and I suspect a number of you may have answered that survey that we sent out in January, where there were a list of about 30 topics. And so I'm absolutely delighted to say that we had 550 replies, which I think shows there is real interest in having a day like this. And so we decided then to take the top 5 topics, and they're the ones that we're covering today. We may well have other events where we'll cover some of the other ones, or there were enough topics there that we could have a day on women's health and a day on men's health. So we may do some more depending on the success of today. But what we've done is we've decided to make this as widely available as possible. So we're delighted to have you people here in the room, but we also have a number of people online. People have registered to go online. And then for those who are unable to actually attend the event today, we're going to make each of these presentations available on YouTube, and we'll make them available to the surgeries for them to send out the link, so that if you or any of your friends want to watch the presentations at another time, you can just go onto the surgery website and we'll let you know when they're ready to do that. It could be a week or two before that happens. But anyway, I hope you enjoy today. Thank you for taking the time away from a lovely sunny day. And we hope you enjoyed. There should be some very interesting presentations today. And I'm going to hand over to Jenny Rogers, who's going to introduce our speakers for this morning. Thank you.
Morning everybody, I'm Jenny Rogers. I think some of you may know me. I'm the patient group leader at Streatham Common Practice. Are there any people from Streatham Common here today? No? Not too many faces. Right, welcome to Border Gardens. This is the last event we're having here before the building's being refurbished, and then hopefully Streatham Common will be moving in and this will be their new premises. So, again, welcome everybody, and I'd like to introduce the first of our speakers, and it's Christine and Shanta, and they're respiratory clinical nurse specialists at King's College Hospital, and I'll let them introduce themselves. Thank you very much indeed.
Good morning and hello to everybody. Thank you, Jenny, for that introduction to us. Thank you very much. I really like to thank you for inviting myself and Shanta to come down to participate in this health promotion event. It's really fantastic. I really do love that the title, Help Yourself to Better Health. Isn't that fantastic? It's very motivating. Hey? So I want to also welcome those who are online. Hello, and thank you for being here as well. So I want to tell you a little bit about our team. It's called the Integrated Respiratory Team. We're based at King's College Hospital, South East London. And it comprises of a large team, and we have quite a few services. We have the tobacco dependence service for those sick smokers. Okay. We also have an oxygen service for those who may need oxygen at some point with low oxygen levels on rest. So we do that assessment process at King's. We also have a pulmonary rehabilitation program at King's, and we have about 3 or 4 sites, don't we? We have King's, sites at King's, we have Dulwich, Brixton Leisure Centre, and I think we may still have Streatham. Okay, so we can invite you to come along to those sessions. It's very exciting. We also have, we also are actually blessed with a team of psychiatric team and psychologists. So we're all there, really, when you come to hospital, which we really don't want you to come into hospital, we have a range of services to support you at the beginning of your journey and to the end. And that's really important, isn't it? You agree?
Yes.
Oh, thank you. I got a little bit of a response, thank you. So we really are keen about early diagnosis and evaluation of lung conditions, because if we don't do that earlier, that disease can progress and you become ill. And so that's worse outcomes. We are actually serving in the borough of Lambeth and Southwark, but we also take on referrals outside of that. Okay? And we're actually managing, which I should have said, the speciality of asthma and COPD. Okay? Just see wave of hands, who's got what? Who's got asthma? No? Anybody got COPD? All right, we don't need to say anything about that. We're just going to be here. Anybody who's got a lung condition, it doesn't really matter. This kind of talk will be really quite beneficial because a lot of us are having health challenges. And today, really, what we want to do is to help each other to improve our current situation. Our health challenge may not disappear, but we can do something to improve it. Hence that title, Help Yourself to Better Health. Okay? I'm going to allow Shanta to do the first session with you. That's all right.
Hello, my name's Shanta. I'm one of the respiratory physios from the integrated respiratory team, so I'm based in the community. First of all, can everyone hear me fine? If I'm talking too fast, which I tend to do when I get in the flow of things, or I'm talking too quietly, can you just raise your hand and I'll know that I'm doing that already? Okay, so we're going to start to talk to you about living with breathlessness. And the first slide, we're kind of thinking about what is breathlessness? So breathlessness is a completely subjective symptom. So you can have 2 people with the same type of lung disease or the same heart disease, and they can be completely different. They can find their breathlessness is so different. And it's really appreciating and acknowledging those differences in the experience. It doesn't invalidate it. It doesn't mean that it's not there just because somebody feels a lot worse with it. It's their perception of how things are going and how they're feeling. There are so many different medical conditions which can make you feel breathless. Things from lung disease, that's obviously our speciality, heart disease, liver disease, kidney disease, cancers. Everybody feels breathless at some point or other. You can have perfectly healthy people that are feeling breathless. So if we think about us here in the room, what do we experience when we start to feel breathless? That's my question to you guys. How might you look if you're feeling breathless or you've kind of overstretched yourself and you're doing a bit of exercise? What things might you notice happening?
Get dizzy.
Okay, yeah, you might feel some dizziness.
Face going red.
Yeah, face going red.
Feeling panicky.
Yes, and that's a really big one that we're going to talk about a bit more. So there's lots of different symptoms that come in when you're feeling breathless. And I think you kind of hit the nail on the head there with where we're going to start the talk about the symptom of breathlessness. A lot of these symptoms overlap with that feeling of anxiety. So somebody, if I exercise, and when I do, I start to feel really short of breath. If I've got a patient, they tend to start then unwell with their breathing. They might start to feel dizzy, faint, sick, sweaty, and that's just the being unwell. They might feel like their heart's beating really fast and pounding. Now we couple that, all of that falls in the middle, doesn't it? Overlaps with this anxiety. They get shaky limbs, they might feel disconnected from their body, and I think it's really appreciating that those things hugely overlap. So if we go on to the next slide, because I kind of skipped ahead a bit there, got too excited. So when we're thinking about those symptoms of when we're exercising, so we've mentioned that you might we mentioned some other bits and pieces, but some of the other things we might feel about is we start breathing through our mouth. You take much bigger, deeper breaths. You might find that you're either leaning to kind of recover, putting your hands on your hips, trying to catch your breath again. And we call that fixing your upper limbs, where you're kind of propping yourself open at the top of your chest. Now these, when you're doing them for a short period of time, is completely normal. You're just recovering from feeling breathless. But what can tend to happen over time is you start to develop a pattern of doing that all the time. When I'm doing this, I'm using my neck muscles and the top of my shoulders. Those muscles, they don't really have the stamina to be sat there the whole time propping and holding up the top part of your rib cage. And they start to get really tired. They're not as efficient as doing that job, and kind of feeds into you starting to feel a bit more breathless. And we're going to come back to that in a little bit about things that you can try to make that feel a bit better and how we can improve on that. So we've kind of been talking about some of the breathing aspect of things, which feeds into that big cycle of feeling breathless. Now we're going to start to think about the thinking, which you touched on a moment ago when you said you start to feel a bit anxious when you feel a bit breathless, or one person could feel a bit anxious when they're breathless. The sensation of being breathless, it's incredibly frightening. Somebody with lung disease described it as feeling like they're constantly drowning when they're feeling breathless. So we've got this frightening aspect of it. They're also not knowing what's coming next. If you're having an episode of feeling really breathless, you start to think, oh, what's happening here? Am I having a heart attack? Am I going to die? I don't want people to see me like this, especially if you're out and about in the community and you start to have an attack with your breathing and feeling breathless. There might be past experiences that are feeding into that. You may have had relatives that have had breathing or heart conditions which make them feel particularly breathless. And you start to think of those memories of them being unwell with their chest. And it all kinds of starts to feed into this, oh, I don't feel really good about this, I'm starting to feel a bit anxious. And like I mentioned before, everybody experiences it very differently. So you can get a perfectly healthy person, like we spoke about before, who feels breathless and kind of feels panicked. Then that can feed in, if you've got lung disease, you've got a very real reason why you're feeling that way as well. And it's difficult to tease apart what's what and what's causing that feeling of breathlessness. Okay. So we've spoken about the anxiety. I came into that a bit too early. So we've kind of covered some bits and pieces about what it's like to feel breathless and some of the thoughts that might go through your head as you're feeling breathless. Then I think this might be, I know most of you don't really have you've mentioned you don't have a lung or heart condition, but when you have a chronic illness, it can really affect your perception of yourself and your relationships and your identity. There's the who I am versus who I was. And when you have chronic illness, these things change, don't they? You're not necessarily the person you were before. You can't do the things that you may have done, and how you see yourself changes over time. And I think there's many different facets to this, which is really important to recognise and to understand. So there could be like the change in the physical appearance. If you're feeling more breathless, you might not be doing as much. It might mean you put on weight. Or it could be that you're breathless and it affects your appetite and you start to lose weight and you don't feel like you look the same. Sometimes it's just the energy that's needed to be able to do things like do your hair the way you'd like to do, or put makeup on like how you'd normally present yourself. And these all kind of then feed into how you identify yourself. Then there's the capabilities of all the different things that you want to do with your time and how you normally spend it. The role you take in your relationships with your family and your friends. And it's trying to recognise how your condition is impacting upon those aspects of your life. Really noticing that those gradual little changes of things that you start to avoid doing. So for example, my mother doesn't have a chronic illness, but over time she's finding that her mobility is changing, and she's really starting to notice that impact upon what she's able to do with her grandchildren. And she finds that quite upsetting at times. I can see her getting frustrated with trying to chase after someone who's very little and not really being able to keep up with them. So I think it's trying to acknowledge that those changes are happening and kind of identify them and see what things you can do, because there are a lot of things that, little tweaks that we can do to make things more achievable and feel easier. Oh, and particularly if we think about now, when we're out in public, what with the pandemic, we're also paranoid about coughing, aren't we? You feel a tickle going in your throat, like, oh my goodness, please don't let me be coughing on the bus right now. Everyone will see me and they'll be looking around. So if we think about somebody with lung disease or heart disease, cough and being breathless is such a natural part of your day, and you start to think, oh, I'm dreading going out. I don't want people to see me coughing and be looking at me. So over time, we've kind of discussed those different ways that your perception of yourself has changed. What starts to happen? You might start to avoid activities, which we'll come back to a bit later, but then that starts to have more of an impact on your breathlessness and can make it start to become slowly worse. You might avoid seeing certain people because you don't want to feel showed up for not being able to do the things you'd normally do. It might be for somebody I was seeing yesterday, used to go to the pub every day but to meet friends, and they found themselves getting really embarrassed because when they were there, actually the walk to the bathroom was a real struggle for them. So they just stopped going. And that was their social life. That was how they stayed in touch with the community and who they saw. So we start to slowly become a bit more isolated because of these health problems. And I think, as I said, chronic illness has so many different facets to it in terms of feeling really tired and fatigued particularly, that can play into it as well. So you're having all of these thoughts, all this stress and this anxiety which is feeding into your breathlessness or just into your everyday life. And what happens? How do we deal with this? You might come across me and Chris and we start to talk to you about cutting down on smoking and watching your weight, which can feel at that point a bit impossible. But I think it's really being mindful of that. When we talk about smoking and weight management, these have a huge impact on your breathlessness. So for people with heart and lung disease, the impact of smoking is massive. So we need to start to think about how we can look at cutting back and making achievable changes to try and either cut down or stop smoking. It's an addiction, so you need to be sure that you're getting the adequate support with it. You wouldn't expect an alcoholic person to suddenly go cold turkey and be fine. So why is smoking any different? And that's why we try to help support you with using nicotine replacement products. So you address the actual nicotine side of things. The next thing we need to think about is the habits that come around with it. One of my colleagues, Aaron, who's from the tobacco dependence team, he's a real advocate for thinking about every time you take to smoke a cigarette, you're actually taking time out, aren't you? You'd walk off, take a few moments, be disengaged from all the stressful stimulus around you. You take those few minutes to yourself to recenter, to think about something else. Now we think that, oh, that's the cigarette that's giving me all that stress relief. But actually, how many non-smokers can say that repeatedly throughout the day? You sit there and take a couple of minutes to yourself, away from everybody, go outside and just switch off. And I think that's a really powerful thing to think about, is when we think about quitting smoking, is making sure that we take that time for ourselves to kind of de-stress. So we've spoken a lot about some of the aspects of kind of being holistic and thinking about how your life can impact on your chronic disease and breathlessness. And so now we're going to have a little bit of a think about strategies to manage feeling breathless. Which, as I said, I know a lot of you don't have lung disease, but actually a lot of them are quite calming anyway, so it might be, for you think about them as being like a mindfulness activity or something to kind of relax. So, we're going to start off with some what we call diaphragmatic breathing, which is a kind of a fancy way of saying to breathe down into your belly. So I need to be careful of the mic because I don't make lots of muffling noises. But what I'd usually advise everyone to do is pop their hands on their chest and on their stomach. So if you all have a go for me now, if you've got a free hand. And so what I want you to do is to gently breathe in through your nose. So 2, 3, and out. Now, get into a rhythm of breathing in for 3. 1, 2, 3, out, 2, 3. Timing doesn't matter so much at this point, just get comfortable with that flow. Now, as you're doing it, I want you to think about keeping your shoulders nice and relaxed and breathing into your stomach. So the idea is you want to fill up with air down in here, because this is usually the least affected part of your lungs with lung disease. It's also, for people who don't have lung disease, the bit that has the most blood in it. So you're going to breathe in deep down to your belly and out, 2, 3. And what I like to do when I'm teaching this is to think about a wave coming in. So the waves come in into the beach, for 2, 3, and then the water just subsides away off the beach, and thinking about that noise. 2, 3, and out. Okay, so when we do that, you know how earlier I mentioned to you about fixing your upper limbs when you're feeling breathless? Because we're relaxing our shoulders, you've kind of stopped doing that. You've stopped fixing, you're letting these muscles relax off. As I said, you're breathing down to the pit of your belly, so you're using the better parts of your lungs to breathe. So that addresses that kind of thing. And it's something you can do to kind of take control of your breathing for a moment. The idea is that when you practice these things regularly, that if you're if you're unwell with your breathing, or in a bit of a crisis mode if you're having a wheezy attack, that trying to implement that time can just calm things down a bit, bring some attention to it, and slow things down. There's other things you can use to try and get on top of your breathing when you're having a breathlessness attack. Some people like to use breathing in a rectangle. I've got a perfect rectangle next to me, haven't I? So the idea would be is that you follow the outline of the rectangle in the room. So it might be a picture frame at home for you. So as you go along the short edge, you think about your breathing in. So you breathe in and follow it. Then as you breathe out, you follow the long edge. And as you kind of get on top of your breathing, the idea is that you slow everything down. When you've got lung disease, especially COPD or asthma, and you've got some obstruction, you want to be breathing out for longer than you're breathing in. And with any of these things, as you start trying them, and particularly if you're breathless, it's going to take a lot of practice. They're good to practice when you're feeling well, so that you can implement them when you're not feeling so well. So we've spoken about breathing a rectangle. Another one that, well, you've just seen me doing it a minute ago, I really like is counting your breath. So if you're feeling particularly breathless, or even for if you have anxiety attacks, sit there and take note of your breathing and start to count for when you're breathing in. So it might be that you can't even count to 1, you're just that quick. Slowly bring attention to try and bring 1, 1, then build up to 2. Stretch it to 3, to 4, and see what's natural for you to try and do nice long deep breaths. And it's that counting that breath can take some of the attention onto the number and take it away from those feelings of panic and anxiety which can come along with feeling breathless. Another thing we'll go through is a distraction technique using the 5 senses. Now, I have to be honest, I used this one for actually when I was in labour, and I found it really useful, so mine's really vivid. The idea with these distraction techniques, and when you're it's a visualization exercise, is that you practice it beforehand so that it feels really real to you and vivid. So that when you're in a moment when you're struggling with your breathing, or with any maybe it might be pain for some of you, that you can pull on that memory of that visualization. So for mine is you start off on a busy road, because that's when I'm feeling stressed. You turn off the busy road and I go into a courtyard which leads onto a garden. And that garden has a water feature in it there. I can hear the water trickling down. I can hear that breeze. I can feel the sunshine on my skin. I can smell jasmine, because I love the smell of jasmine. I can smell that really pungently, and I think about all of those different sensations that are going on. My toes in the grass. So for you, you might hate a courtyard garden. So you think about a special place. It might be real, it might not be. And really think about that place, and try and think of all the different senses, what are going on. And the more you practice it, the easier it is to then implement, as I said, when you're not feeling well. And that's the idea in terms of, as we said, because there's such a huge overlap with the breathlessness and anxiety, is to try and bring attention to something else to kind of help that feeling of calming it down. Another thing you can try for breathlessness, and this is more actually focused with people specifically with lung disease, is fan therapy. So this part of our face has lots of receptors in the skin, and when there's a breeze going on them, it calms down the brain's feeling of being breathless. So you know the little travel fans you get with the 3 blades? So you can just pop that on, direct it at your face, and that can stimulate your brain to think, oh, actually, I'm not feeling as breathless. And it just calms down the sensation of it. Other things you can try is with a wet flannel, it's dabbing down in your face, and that cooling of the water has a similar effect. So it's just over this part of your face. And then finally, this again is a bit more disease specific for people with asthma and COPD, is pursing their lips when you're breathing out. So because of the damage done to the lungs, it's a bit hard for you to get air out and it can get trapped. So when we purse our lips and breathe out, it gives a tiny bit of back pressure, which just means you can empty your lungs more fully. And then you can get more fresh air in, and that can help with that feeling of being breathless. I think, if you mind moving to the next slide. So we're going to come on to think a bit more about functioning and thinking about activity. So what tends to happen, and this, I'm talking about this in the context of breathlessness, but this happens to other people with different conditions. So sometimes pain can feed in with this if you've got arthritic pain. You do. Oh, can I go to the cycle of inactivity? I'm not sure what happened. Sorry, there. So what starts off with is you become fearful of an activity that makes you breathless. So like we discussed earlier, it might be walking along to the shops. It might be climbing stairs. Because you're fearful of it, you avoid it. And then you start to do less activity. So over time, you're doing a bit less, a bit less, a bit less. And when you look at the whole day, there'll be lots of tiny little things you might be avoiding, but actually the sum of them is quite great. Then slowly over time, your muscles, they start to become weaker because they're not being exercised like they used to be. These weak muscles, they actually start to need more oxygen because they're not working as efficiently as they did. You start to feel more breathless, so you do less. Your body can't then cope with the stress of it, and it just spirals. This is something that's modifiable. So if we go on to the next one. One of the most important things for people with lung and heart problems is exercise. Like I said, that's completely modifiable. We just need to identify what it is you're struggling with and kind of make accommodations, and also need to exercise regularly to be able to build up our strength. So this is a positive cycle of activity. So you keep doing your activity, or you do more. So we should all be exercising, I think it's 150 minutes or 75 minutes of being really vigorous. But the idea is that separate exercise. So it's good to be generally active, but it's about keep raising your heart rate and sustaining it for a period of time. So it's really important to be mindful of that, because quite often people be like, oh, well, you know, I do my gardening and I pot around doing this and that. And it's not taking away that there's not an activity that exerts you, but it's not the same as doing focused exercise where you're strengthening up all specific muscles and having your heart rate high for a sustained period of time. So we engage in this exercise, and it starts to mean our muscles become stronger, they become more efficient, and then over time you start to feel less breathless, and it becomes easier and you feel better. And this applies to any of us. If I don't go for a run for a while, which I haven't, so the next time I go, it's going to feel like a horrible slog. I'm probably going to hate it. But the time after that, it will be that bit easier, and the time after that, more easier. And you build that exercise tolerance. And that's the same with people with lung disease and heart disease. We can gradually build on that and make you able to do more before you get more breathless. Now, I've mentioned it as terms of exercise. Ideally, everyone would be generally active and doing exercise, but it might come to a point with your disease that actually it feels like a bit too much of a challenge, or you just don't feel comfortable with it, you're not sure how to go about it, and doesn't feel like a realistic goal for you. And that's where you might come to see us in pulmonary rehab. So pulmonary rehab is an exercise class for people with lung problems. There's also cardiac rehab as well for people with heart problems. So the idea of that is that you come to see, we're there in the gym, or it might be for some places they have it based in hospitals as well for people who really struggle with their breathing. That you come see us, we help you to exercise, and we gradually build you up. We're not expecting you to turn up and be running on a treadmill. It's all aimed at where you are at that point in time. So we agree a plan with you, and over a course of, I think it's a couple of months, 6 to 8 weeks, we gradually build you up so that you're able to do a bit more, and feel confident and comfortable doing this. Because that's, for anyone, it can be really daunting starting off a new program of exercise. And then gradually over time, then we'd hope that would impact, not gradually over time, it does impact on your lifestyle. You'll notice big changes of what you're able to do and not able to do, what you're able to do from having done that exercise. Okay, now I think Chris is going to continue talking about that functioning side of things and how we can enable you to do a bit more.
Thank you, Shanta. Hello, everybody. Can we kind of like move about a bit? Have a little bit of movement? Thank you for that wonderful presentation. Let me just get out that light. Thank you for the presentation, Shanta. Yeah, if we don't use it, we'll lose it. Is that right?
Yes.
If we don't flex that muscle will deteriorate. And so as we discussed about this inactivity because of breathlessness, we're going to look at some strategies that will help us, to do a little bit more. We want to get a little control of what's happening to us, don't we? Don't you think?
Yes.
Yeah. We can't have a condition taking over us. I mean, so we want to try and implement things that we can have a level of a little control. Some of us won't have that capacity anymore because we're so severely ill, but we have a mind and we should be able to choose and make decisions for ourselves, even if it's in smaller matters. Even if you make one small change today from the techniques, I keep going into that light, you make one small change and it's consistent, you will see the difference, believe me, you will see the difference, and that might give you a lot more confidence to do more, to do something else, add something else to your program. So what I'm going to talk about is a little bit about fatigue and weakness, which comes into that cycle of inactivity where your muscles fail you, you get more bad days than good days.
Yeah.
Yeah? And so I'm going to talk a little bit about that. What we need to do in terms of that, you've got to know what is it that you like doing. Yeah? You have to identify an area that you like, or a task or activity that you really want to do. It's very important to you. Once you recognize that, that's good. You say, that's very important, I want to do that. Whether it's, maybe it might be having a shower every 2 days and you find that difficult. So you'll say, that's important for me to do that and I want to do that on my own. So you have to make a plan for that. Then you have to look at tasks that you want to do but you find difficult to do. Does that make sense? Good. So you would have to then consider, how can I make that task easier? What do I have to do? Do I have to do small bits and build up? Because sometimes in our minds we think, yeah, I can run here, I can do this and I can do that, but your mind's saying this and your body's saying, no, hold on, stop here. You can only do this bit at a time. So sometimes we want to do things really quickly, but our body's not able to manage that. Is that all right? So we have to make a plan. So once we've organised the plan, say example, you might be able to get a family member to help you out. Yeah? Say example, so just give you some examples here. Washing and dressing. I don't know if anybody's got difficulty in washing and dressing. That might be a problem for some people. So how would you plan your day to get yourself, to attend to your personal hygiene needs? You may have to perhaps get all your clothing and put it to one side on the bed a couple of days before, or if you've got a hospital appointment and you know that the ambulance crew is going to come 2 hours' time, maybe over a period of few days, you would be putting things down to one corner. You may pack your bag, you may do whatever, put things to one side. Then you would probably have all your toweling, you'd probably purchase a toweling dressing gown. That would be quite useful, because if you get wet in a shower and you go into a shower, you can, when you come out, you can put your toweling dressing gown on you and sit down and that will dry itself. Does that make sense? You don't have to move around and rub yourself. So we said about laying out toiletries. In terms of in your shower room, when you go in your shower room, it might be quite hot. So maybe you might, if you're on your own, you might want to leave your door open. You might have a little bit of the window open a little. So, because sometimes it can be quite smothering in a warm shower. You use warm water, not hot, so you're not affected by the steam and heat. Make sure you have some grab rails if you need that in your house, or you may have a perching chair. Okay, that's some ideas what you can do. If you have difficulty, you can have zip-up garments. You can get help from the occupational therapist. Yeah, you can find aids and adaptations for your home. So that's some techniques. Talked about washing and dressing. Let's talk about a little bit of food, because I know we've got kind of like a short time. And remember, when all these activities, what we want to achieve, we can do that bit by bit. We have to prioritise them, we have to plan it, you have to do pacing. Pace yourself so you don't get over-exhausted. You might wake up one morning and feel really great. I can get this done, get that done, and then for the whole week you're flat. So you don't really want that. So we try and do a bit of activity, bits and pieces, and you know, a bit every day is better than nothing. Do you agree? No? Does anybody agree with me out there? I feel like I'm on my own. Okay, all right, cool, and that's really wonderful, thank you. We're going to quickly go on to nutrition while we're talking about food. It's very important with people with lung condition to eat well, and we often have the problem. So the importance of nutrition is why? One, to build up your immune system. You know, we've got lots of viruses all over the place now, yeah? So we have to eat food like medicine. It's an art, a science. And many people with lung conditions are unable to eat. They have lost their taste for food. They have no appetite anymore, yeah? And this for different reasons. And by eating well, by having a variety of food of choice, we can reduce the risk of infections and we can recover quickly, okay? That's really important food. Individuals with lung disease often experience shortness of breath, which is a problem, and they may use up to 10 times the calories of a healthy individual trying to catch their breath. See how important that is? You can walk 5 steps here, but for somebody with lung disease, I can walk there, it'd be like running a marathon. Breathing, which is normal for us, is difficult for somebody else. So what we don't want is malnutrition. You know, you can become not eating well, the right foods, you lose weight, then your respiratory muscles get weak, you're not able to expand them very well, your walking ability decreases because you just feel fatigued. That's why Shanta was talking about pulmonary rehabilitation. It's a lifesaver because when you're, come on physio. Quadriceps gets weak, you're in trouble. Especially when you spent some time in hospital, you know, and they have you in bed for 4 or 5 days, you're in trouble. We're going to have to keep moving, yeah. Otherwise, you lose that ability to walk the distance. So hopefully you don't go into hospital. If you ever do go into hospital, we need to try and rehabilitate quite quickly by getting out of bed and try and do as much as we can. So we talked about malnutrition. Obesity could be a problem and still being malnourished because maybe they might be on long-term steroids, okay? And so that can make you put on some weight. So we need to look at some reductions. And also people who've got sedentary lifestyles, people are housebound, you know, they're obviously going to be a bit obese. And so that's going to impact their life. So weight loss, I think we will probably need to seek your dietitian to have some input from them. And we have to be wary about osteoporosis. Could you tell me what 5 food groups could you name that we need? Come on. Come on, I'm getting you. Sorry? Yes, carbohydrates, is that?
Yep.
Protein? Yeah. Fats? And pulses?
Yeah.
Yes, perfect, brilliant. So we need a protein. Why? Sure. To build in, yes, keep your muscles. That's what we want to do. And that's why we go to pulmonary rehab. So we can learn to build those muscles, carry those bags and walk a little bit of a distance. And then we got carbohydrates. And why do we need that? We need that for, thank you. I've got some nutritionists in the background here. Thank you so much. You're making my job much easier today. And yes, vitamin and minerals, especially what type of fruits and vegetables do we need? That's right. So we've got this. Hopefully you can download this thing. Yeah, it's the Eat Well Guide. Yeah, it's absolutely fantastic. Okay, it's got loads of vegetables on the way. Yeah. Loads of vegetables on one side. And you've got your bananas, your vegetables. That's to help to build the immune system. Come on, we've got to remember, nowadays there's a lot of respiratory infections. You've got to build your body up by eating proper food if you can. And a lot of us have to get frozen food. Maybe you have to get frozen vegetables. You can have tin fruits as well. You may have to shop online because there's lots of barriers to eating nowadays, isn't it? There's lots of barriers, and you may have to get help. You may have to get a family member to cook food for you over a few days, and you can freeze it and add a few. So we have to think and be a little bit creative with that. Or you can get your food delivered online. Those are some of the things that we can think about. And say, these are carbohydrates. We've got the pastas, the bread, the rices. Yeah? You like your pastas? Pasta tuna, whatever? Yeah? Cool. Yeah, so that's for what? Yeah, energy. Okay? So we've got all these important foods. What are some of the problems that we get with eating? What is it? So we mentioned some of the barriers. What are some of the problems we get with eating? Pardon? Ah, thank you so much. Oral, important oral care. Okay, you know with your inhaled steroids, you're prone to get a fungal infection if you're not rinsing your mouth after. If you've got ulcers and so forth, that means you're probably run down, you're not getting all your vitamin and minerals in. You remember your mucosa line in your mouth becomes dry, you're going to get sore lips, sore mouth, and run down. So we need to drink. I believe in washing your mouth with salt and water. Yeah, get rid of all that horrible mucky down there. Make sure you clean yourself properly if you can. Yeah, so that's important, and get your mouth sorted. So we talked about that, clean dentures, and in terms of if you've got poor or it's very sore, we can probably look at softer diets with more sauces. Try and cook a little bit more casseroles. You wake up in the morning, you've got a just throw a thing in the pot, do some stews. Do you know what I mean? With protein and everything else. Anybody got any recipes to share?
And I think that's particularly important, isn't it, with the dry mouth aspect of things.
Thank you.
And if you're breathless when you're trying to eat, and it takes you longer to chew on things, if you've got something soft and saucy, it's quicker not quicker, but it's easier for you to have it ready to swallow. So if you're breathless as you're eating, it's an easier thing for you to manage to eat.
Thank you so much. Yeah, so you get your cheeses, softer diets. Yes. Yeah. And you know what? You can do a smoothie as well. Some of us don't like those nuts and stuff. Sometimes they're a bit hard and to digest. You can actually put them in a little bit of water overnight, or you can put them in a smoothie. There's lots of good things you can do, and these little things that you practice every so often, you will actually feel the difference. All right. So we talked about coping with a dry mouth.
We've just got a couple of minutes left now, Chris.
Have I? Oh, yeah. That's sad. What about a couple of minutes? How is everybody sleeping? I'd say, yeah, it's always a problem, sleep, isn't it? Sleep. So we've got a couple of minutes. Forget about the Coke and the caffeine. If you're going to have your caffeine, have it in the day, and not such a strong one, all right? Because that it keeps you awake at night. Coke is not the best food to have. It's got too much sugar in it, okay? Too much sugar, and it's not going to. You don't feel well when you have a lot of sugar in your body. In fact, you're more prone to have more disease if you eat sugar. So we must stay away from a lot of those horrible drinks and stuff. So at night time, what we do, have a darker room probably, yeah? Have a calm and nice herbal tea. Will that interest anybody, herbal? Okay, that's good. Anything else? Anybody else can suggest anything that they do, a hot drink? What do they do to get to sleep at night?
Ovaltine.
Oh, Ovaltine, yes.
Just plain water.
Plain water, and it's good. So you must drink in the day and actually get your water intake in as well. All right? About 8 cups a day, so that you're not weaning at night. So just, yeah. So, and this nice calming music. Thank you. I've been told to stop. Thank you so much for your participation. It's time for question and answers.
We do have some leaflets on the next slide, which you've got with us here, but for those who are at home, there is some references for some written things you might be able to have a look at to go into a bit more detail on some of the stuff we spoke about. I've got a lot of leaflets.
Yes.
I think what I'll probably do is bring them outside
because there's several. Got a bit carried away.
Thank you so much. That was so interesting. I think a lot of people are going to benefit from that. Be able to look afterwards on YouTube. I'd like to just give you a little bit of a thank you present.
Oh, thank you.
On behalf of the PCN.
Thank you very much.
Thank you so much.
Very kind.
Thank you so
Thank
much.
you.
It's very nice of you.
Okay, thank you very much, folks. We're on to the next one now. Thank you very much indeed.
We're just going to have about a 2-minute break while we get ready for the next session.
So if you'd like to have a little refreshments or you can walk down the tables and have a little and come back in 5 minutes.
Got away with this.
People enjoyed it online. No questions,
perfect.
but a lot of good.
Oh, what did you say?
Just some people were enjoying it.
Oh, good.
Yes. Yes. Shall we bring this outside then? And, should we
Maybe.
get our stuff to go? We'll bring it outside. Won't be a minute, my dear. No. No, don't worry.
I can hang around for a bit, yes.
You just be careful.
Perfect.
Alright.
I'll pop
I'm glad
that
to
on
have
there.
you here. Thank you, Susie.
Oh, good. No, we overran. I'm sorry. It was me.
Yes, I've got everything. Thank you so much for having us.
Pop this out there.
And I hope everything goes well with the rest of the editing and the her days. Yes, perfect. Perfect. Thank you.
Sorry, ladies.
Thank you.
Thank you.
We're out now. Thank you.
We'll share our information.
Like this and not use it. God, what a waste of money. I'll get you some more. I've got.
I always get into the little things that's going on at the exchange service.
Oh, excellent.
Well,
the exchange is and you can do it because you'll be in the room.
Sorry?
You can join in.
Yeah, I mean, this isn't a Dementia Friends session. I haven't done it because it takes quite a long time, about an hour. And I think my slot was about an hour. Yeah. So it won't be a Dementia Friends session.
But it's interesting because I've got an autistic son. And it worked for him.
There you go.
Yeah, I said to him, tell me how many things, and he said, well, first of all, I've got to find the fridge where the milk is, all that sort of thing.
In fact, you just reminded me. I'm saying it's not Dementia Friends. I'm going to get.
There are seats in the front here if anybody would prefer to sit a bit nearer, sit round here. We have to sit right back. Come and sit near in the front if you prefer.
Has everyone got a bingo card? Has everyone got a bingo card? I'll make sure they've all got bingo. Yeah, brilliant. That's cool. Bingo cards. You got a bingo card? Brilliant, excellent.
Tony, apparently we haven't been able to circulate online the bingo cards. So
right.
people that are watching on
that was,
live won't be able to take part.
All right.
So it's one of those things.
No problem.
I'll do you understand? I mean, there's a seat near the front, if you like. Seat near the front, if you can. So I people don't sit at the front.
All too frightened.
It's at school, isn't it?
Yeah,
People
yeah.
all sit at the back. Tell me when you're ready, Nick. Good morning, everybody. Once again, we're on our second visitor and guest. Very, very pleased to have you, Tony.
Thank
This is
you.
Tony Abacha. He's from the Home Instead, and he's going to be talking to us about all sorts of things.
About dementia, yeah.
Dementia.
Yeah. Okay, dementia. Yeah, about dementia. Thank you. Yeah, hi everybody. My name's Tony. In my day job, I run a care company called Home Instead. I'm also a volunteer with the Alzheimer's Society, and I'm a dementia champion. So I go out and give talks on dementia. So today, I've very loosely structured today's presentation on Dementia Friends, and everybody hopefully has got a bingo card. Have you all got one of those little cards? Yeah. Brilliant. No? Okay. Right, okay. So what we'll do is we'll just hand out, Susie, gentleman, yeah, oh you haven't got, yeah, sorry, that card, yeah, the bingo card. I better take it, go on, yeah.
Are we going to be winning some?
We are going to be winning something today, yeah, so here we go. Yeah, so what we'll be doing is, I'll just give you some facts and figures first, but then afterwards we're going to be running through this dementia bingo. So what I will be doing is I'll be reading out 12 statements, and what we have to do, or you have to do, is circle the right, what you believe to be the correct answer, okay? So we'll come to that in a minute. So I'll just give you some background on myself. The reason I became a dementia champion is because I run a care organisation. A lot of the people I look after have got dementia. And I noticed that a lot of friends and families and relatives were coming to me and say, you know what, I love my mum and dad, but with their dementia, I'm getting really frustrated and angry and resentful because their behaviour is so awkward and their language can be so abusive, and I'm getting really, really fed up with it. And it suddenly occurred to me that I had to explain, well, mum and dad don't mean to be like this. This is just what dementia does, right? That's just the way it is. But the problem is that, you know, we always say forewarned is forearmed. So if you know what's coming, then you can prepare for it. Quite often what is happening is people are being told they've got dementia, but they're not told what changes may occur, and nor are their friends and their families. So when these changes occur, it comes as quite a shock. So the example I always give is, you know, if one day mum walks in and she's got her knickers on her head, you might think, oh my God, and you know, it's going to be a very emotional response, like, take those, what the hell are you doing? Take those knickers off your head, right? And that isn't necessarily very helpful. But if the doctor or the health professional had warned you and said one day, because mum's got dementia, she may mistake her knickers for a hat, and when she does do that, what you need to do is say, Mum, that is a lovely hat, but how about we try this one? This is an even better one, and I'll swap you. Right? And then that's a nice exchange, it's nice and positive, and everyone goes away happy because you know what to do. Okay, so as I say, the problem is people are not told what to expect. And so when things change, it comes as a bit of a shock, and people go, oh my God, you know, the sky's falling down. So hopefully, you know, today I'll give you some tools and techniques that will help you or people living with dementia. So some facts and figures about it. You know, at the moment, there's 850,000 people in the UK living with dementia, and that is expected to increase to about 1 million by 2025. So, you know, we've got an ageing population. You know, dementia is just, it is on the increase. And we know at the moment that there are 45,000 people under the age of 55 with dementia. So it's not just for old people who get it. This is a fact from the Alzheimer's. Apparently 2/3 of people who get it are women. Don't know why. Obviously research is going into that. 1/3 of people over 90 will have dementia. And the cost of the UK economy is currently £17 billion a year. So it is a big problem. So the government is investing a lot of time and resources to try and educate people, make people aware of dementia and how we can live with it and help people in the community with it. And at the moment, there's 66% of people, fortunately, with dementia are living in the community. They're not sort of shipped off into nursing homes. And that's fine, because, you know, people with dementia can live completely normally, so long as people like you and me know how to help them, okay? So what we're going to do is, we've got the bingo cards. I am now going to read 12 statements, and what I want you to do is circle what you believe to be the right answer. So I'm going to miss out the word, so you get the hang of it. We'll do the first one together. So the first question is, dementia is not a natural part of what? Now, shout out the answer if you think you know what it is. Aging. Excellent. Brilliant, that lady. We're off to the races. So everybody circle aging, not races. Everyone circle aging. All right, so everyone's got aging circled. Right, now it's eyes down, and it's the first one to get full house. So there's 11 more statements. Okay, so don't shout at the answers. Just circle the answer if you think you know it. So number 2, dementia is caused by what of the brain? Dementia is caused by what of the brain? Circle the answer if you think you know it. That's number 2. Number 3, one common type of dementia is which disease? One common type of dementia is which disease? Circle the answer if you know it. And in fact, that shouldn't be too bad, because I think there's only one type of dementia on your cards. Right, number 4. Dementia is what? Which means the symptoms will gradually get worse. Dementia is what? Which means the symptoms will gradually get worse. That's number 4. Number 5. Alzheimer's disease usually starts by affecting people's what? Alzheimer's disease usually starts by affecting people's what? That is number 5. Number 6. Dementia is not just about losing what? Actually, I've given it to you there. Anyway, I read too much of the question out, but I think everyone's probably got that. So dementia is not just about what? And it begins with losing, so that's a little clue. Number 7. Dementia can also affect people's what? Dementia can also affect people's what? That's number 7. Number 8. People with dementia can still do what effectively? People with dementia can still do what effectively? People with dementia can still do what effectively? That's number 8. Number 9. At any one time, one in how many people over 65 has dementia? At any one time, one in how many people over 65 has dementia? That should be quite an easy one, because I think there is only one number on your bingo sheet. So hopefully everyone will get that one. Number 10. It is possible to do what with dementia? It is possible to do what with dementia? Number 11. There is what to the person than the dementia. And finally, number 12, well, actually, I won't do it. I'll read it out, but I haven't briefed you on this, so you won't know it, so it'll be guess. Dementia Friends, and this isn't a Dementia Friends session, but Dementia Friends is about turning understanding into what? Dementia Friends is about turning understanding into what? You'll know it should you next time do a Dementia Friends session. So, has anyone got full house? Yep. Oh, good. Right. Anybody else? Right. So we've got 2, 3. Right. Okay. Fine. Okay. 4. The answer goes. You should all have full house, because I've read 12 questions. So hopefully you've all got 12 things circled. But never mind. That's a funny old game, eh? Right. Okay. So let's just go through the answers. Right. So number 1 we did together. Dementia is not a natural part of what? And we said aging. Yeah, and the reason is that people think it's only old people who get dementia. I think I mentioned to you before, we know there's 45,000 people in the UK under the age of 55 with dementia. So it isn't only old people, okay? People will say to me, is it hereditary? Can I get it when I'm young? Well, there is one type of dementia that is hereditary, and it's called familial, but a very, very small percentage of people get that. Most people do not inherit it, you don't catch it. It's just there are risk factors. No one's quite sure what causes dementia. And obviously, there's a lot of research going into it at the moment. But being old doesn't mean to say you're going to get it. I have clients who are 101 and 102, and their memories are far better than mine. Their memories are as clear as bells. Okay, so don't think because you're old you're going to get it. This doesn't follow. Number 2, dementia is caused by what of the brain? What did we get? Diseases, yes. And it is a disease. People often say to me, oh, it's a mental illness. Dementia is not a mental illness, right? It is a disease. If we look at all our brains are about so big, they weigh 2 pounds. If you look at the brain of somebody with dementia, the brain is half the size and half the weight. The brain physically shrinks and dies. What basically happens is the brain gets covered in a thing called a protein, and the protein attacks the brain and kills it, okay? So, which is why I always say to people, there is no point in arguing with people with dementia, because the bit that does all the reasoning that was there is no longer there, right? They haven't got that skill anymore, because that part of the brain that did the argument or the logic, and people say, come on, you understand. No, they don't, because the section of the brain that used to do all the calculations and working out is no longer there. So there is absolutely no point in shouting at people with dementia. They will not get it. All that will happen is you'll get upset and so will they. Okay? And one of my clients said to me, you know what dementia's like? He said, imagine a Christmas tree with lots and lots of fairy lights. And each fairy light is a memory, a skill, or a function. And he said, every day I know more and more of my lights are going to go out, but I don't know which ones, and I don't know in which order. But I do know that eventually all the lights will go out, and there'll only be one left, and that's the one that keeps my heart going. So you can imagine it is quite a frightening process, because you're seeing your skills disappear. And it is worrying. I mean, we'd all be worried if today you're this good, and over 6 months you've declined, right? And you can see it happening, which is why a lot of people with dementia are frustrated and they are frightened. We'd all be frightened if we saw our skills and acuity going away, and it can lead to depression. And a high percentage of people with dementia have got depression, okay? And you can understand why, right? Because it can be quite a slow process, and if you can see you're going downhill, you ain't going to be happy about it, okay? So, but as I say, with a bit of education, things can be okay and can be quite manageable. So number 3, one common type of dementia is which disease? Alzheimer's. And Alzheimer's is the most common type of disease, or dementia I should say. 50 to 60% of people who get dementia will get Alzheimer's. And the signs of that are obviously memory loss. But there are other types. You may hear of vascular dementia. Okay, vascular dementia is actually that's down to a circulatory problem. It's not a problem necessarily with the proteins in the brain, and it's caused by a series of mini strokes, right? There's a blood flow problem, the brain is starved of oxygen, you have an episode. Now the thing is, you will not know, and nor will the person with vascular dementia, they will not know they're having an attack, a mini stroke. They'll just carry on. But what you will notice is that they will lose some functionality. And maybe you come and see me today and I can make a cup of tea. You come back tomorrow and I can't. What's happened? The section of my brain that controls making a cup of tea didn't get any oxygen, it has gone. That functionality is not coming back, right? So people can get quite, oh, come on, you could do it yesterday, come on, you must be able to do it today. No, with vascular, it's a very stepped decline, and you can have a stroke or a mini stroke, an attack, and then nothing for days, weeks, months, years, whatever it's going to be, okay? But it is a very stepped decline, whereas with Alzheimer's disease, you tend to find it is quite a linear, it's a gentle decline. But the thing to notice is that dementia is different for everybody. Some people can go get a diagnosis and go downhill very quickly. Other people get a diagnosis and hardly change from the day of their diagnosis to the day they die, right? We don't know. Nobody knows how fast it's going to progress or how we're going to be affected. It is different for everybody. Right, so as I say, we've got vascular dementia. We got, you may hear frontal temporal. All our personalities at the front of our brains here. People who have this type of dementia can undergo personality changes. And I have a client, and she was a lovely lady, and I went to see her, and she said, "Come on, Tony, let's go and have a nice cup of tea." As we were walking to the kitchen, she got a walking stick and went to whack me over the head with it. And I thought, oh my God, and I jumped back. And she went, "What are you doing standing over there?" I said, "You just tried to hit me on the head, Betty." She said, "No, I did not." And that's how quickly she can change, right? So she went from this lovely old lady to, "I'm going to kill you." So, but it can go both ways. I gave this talk and the lady said to me, "Well, my mother got frontal temporal dementia and she turned into the mother I always wanted." And I said, "What do you mean?" She said, "Until that point, my mother had been a complete and utter bitch all my life. She got dementia and she was wonderful," right? So it can go both ways, but just be aware, frontal temporal affects people's behaviors. The last type, or common type, is one called Lewy body. And you may have heard of Lewy body dementias. Now with Lewy body, it's not so common, but people with this type of dementia can have visual hallucinations. Okay, so they can see things, but they can also have auditory hallucinations, so they may be able to hear things, right? And they can also suffer from delusions. So they might have delusions are irrational beliefs. So, which probably explains why people sometimes think people with dementia are mad, because if I'm standing here saying I can see angels and hear harps and I can see God, you're going to think Tony's lost his mind, right? Okay, but I can actually hear those things. But that is a function of the disease, okay? So, you can't have to, with people, you have to accept people's reality with dementia. You can't change it. As I said, the brain, when it's functioning, is so big. When they get dementia, all the mental acuity goes, all the rationale goes, and you can't change their perception. So you need to change yours. So I say Alzheimer's is the most prevalent type. Then we get vascular dementia. Then we get frontal temporal, which affects behaviors, and then Lewy body. People say to me, "Any cure?" Well, there are lots of medications. There are medications for Alzheimer's disease, and more coming on the market. At the moment, there isn't any cure for vascular dementia, right? And it's quite sad. It can be quite abrupt. I had a client who got diagnosed with vascular, went to the GP, and the GP went, "Nothing I could do. Sorry, no medication," which is not great. So, you know, but there are people out there like the Alzheimer's Society, you know, who can give you advice and signpost you to people who can help. Because it may not be medication, but there are definitely talking therapies that can help. I was just having a quick look. Right. Moving on. Number 4 is dementia is what? Which means the symptoms will gradually get worse. Progressive. And that's very important because quite often people think, right, Mum's got a diagnosis, that's it, that's how she's going to be for the rest of her life. Well, wrong, because that's how she is today, but things are changing. You can't see it, but you need to keep an eye on people, right? We had a client, and she's a lovely lady, and our care used to go with her and just sit and they'd have a bit of a natter. That's what she was there. And the lady was very able-bodied. She'd get up. Her daughter made some frozen food, which she'd get out of the freezer, heat it up, and then put it in. Sorry, it wasn't frozen, but she'd put it in the oven. And she had a gas oven, and she used to warm it up and have a natter with a carer. Great. One Thursday, the carer went in, and the lady, as normal, went to the fridge, got her food, put it in the oven, turned the oven on, heated up, sat down, had a nice meal. She said she came back 24 hours later. She walked into the door. The place reeked of gas. And the lady was there with a box of matches and about to strike a match. What had happened was the lady had got the food out of the fridge as normal, gone to the gas cooker, put it in, turned it on. She had an old-fashioned cooker that carries on when you turn it on. It hadn't lit. So she left it with the gas coming out, went upstairs, rummaged around for a few minutes, came back with a box of matches, by which time the whole place was full of gas. And luckily, the gear came in at the right time and managed to run in, stopped to relight the matches, and had to open all the windows. And then we had to ring the family and say, that's it, you've got to turn the gas off because mum is not safe with gas. And they went, oh my God, it's time for the nursing home. I said, no, it's not. I said, mum can't use a gas cooker, but she can use a microwave. So all you need to do is turn the gas cooker off, give her a microwave. She's competent, you know, she's safe. Because you want to keep people living in their own homes, in familiar environments as long as possible. So the point of being progressive, on Thursday she was fine, on Friday she wasn't. Things are changing. So you've got to keep an eye on people. Yeah, and we need to keep making sure that the environment they live in is safe and changing and adapting that environment to keep them safe. Because things will change. So just be mindful of that, okay? Number 5 was Alzheimer's disease usually starts by affecting what? Short-term memory. And that's quite important because there are a number of reasons why people's short-term memory can be affected. One, especially with older people, quite often older people are dehydrated. They don't drink enough water because they think if I drink too much water, I need to go to the loo. And what's going to happen? I might wet myself because I won't get there in time. Or I'm going to get there and I'm going to fall over. I'm going to have a fall. So guess what? Much easier not to drink any water and be fine. Great, it works, but you're dehydrated, and especially if you're taking more than one medication, you can have medication conflict. That medication conflict can cause memory loss depending on the medication because you're dehydrated, right? So that is one reason why somebody might have a memory loss because of the medication. Number 2, people who drink heavily, right? I mean alcohol, they can have memory loss. Now, that memory loss is reversible, but it has the same symptoms as dementia, right? And what's actually causing that is a B12 deficiency. Now, those two things can be reversed. I mean, if you notice someone's got memory loss, then you should go and see the doctor. I mean, I have memory loss. I quite often go into Sainsbury's and I come out and think, oh my God, where have I parked the car? That's quite normal. What wouldn't be normal is if I came out and said, oh my God, what sort of car did I drive here in? That's a problem, right? So we have to, if you notice anyone who's got memory loss, go to the doctor. He will do a number of tests, he'll check your medication, check you're not drinking too much, and if you are, give you some B12 supplements. And another reason, the third reason that people can have memory loss is stress, right? Especially stress caused by loss or bereavement. And I myself, before I did this job, because I used to work in the city before I ran this company, had a really stressful job. And one day I went into a meeting with a number of people, only about 6 people, and I looked at them all and thought, oh my God, I can't remember any of their names. And I worked with them for a whole year. And then I thought, oh God, I better get on with the briefing. And I started briefing them on the project and thought, I can't remember the project. So I got my book and I started reading really quickly. I thought, if I read this, it'll jog my memory. But the problem was, by the time I got to the bottom, I'd forgotten literally what I read 2 seconds earlier. And I winged it, I bluffed it, walked out, thought, oh my God, I'm losing it, I'm going mad, you know. And like most people, I kept that to myself. Because imagine this, we're all here in this room today. If I asked you your name and you couldn't remember, how would you feel? Shocked, ashamed, yeah? Scared? And if I said, right, we're going to come back tomorrow with the same number of people and I'm going to ask your name in front of them, would you come back? No, exactly. Nobody would come back because nobody wants to look stupid in front of other people, right? And the problem that creates is that people start to socially withdraw because they don't want to look bad in front of people. And if you start doing that, you then become socially isolated. Then you're in a spiral because once you're socially isolated, then you get depressed. And it's a downward spiral, okay? So if you notice, I say, the memory loss, what you must do is go to the doctor because the doctor will either review your medication, tell you not to drink so much, and if you are depressed or whatever else, there are therapies, they're talking therapies as medication. But the important thing is you must go because don't do what I did and try and hide it because people with dementia are superb at hiding their dementia. They develop strategies which will throw you off the scent, and it takes years. And we have clients who will write lots of notes and they'll hide them around the house, put the cat out, turn the lights off. You won't know where they are, but they do. And then, you know, typically you ask them a question they don't know the answer to, they'll make light of it. You know, who's the Prime Minister? Who cares? They're all a bunch of crooks. Ha, ha, ha. Deflected. And that is how people with dementia will hide it from you. And as I say, it can be years, because they know their memory's going. But like me, I ain't going to tell you. And so, there will be warning signs. So if any doubt, just send them for a check. Right, so that's short-term memory. Number 6. Dementia is not just about what? It's the same answer, actually. It's actually losing your memory. There's 2. Yeah. Now, dementia is not about... But if you think about this, you know, dementia affects the brain. What does the brain control? Everything. Yeah. So people often think, it's dementia, it's going to be in my memory. But it's not. It's anything. It could be your balance for you. It could be your balance for you. It could be your sight. For you, it could be touch. You know, for you, it might affect your walking. It affects all of us differently. But because it affects the brain, there's a range of things, okay? So it isn't just about memory, says me. So things typically that you'll notice, the communication skills, like I was just then, people struggling to find the name for things, you know, that dog, cat, getting the names mixed up. It could be motor skills. You know, something as simple as not being able to use a knife and fork anymore, or struggling to get the key in the lock, okay? It could be sequencing, so it could be they're putting the clothes on, odd clothes on, odd socks on, shoes on, the wrong feet, wrong colour shoes, getting odd combinations, okay? It could be changes in inhibition, and this means sexual inhibition. And in running a care company, that can be quite an issue, because most of some male clients, you know, to give you an example, we had a chap who was bedbound, 94, and the female care used to come in, and he'd always say, throw back the sheets, say, come on, love, jump in, let's have a bit of fun. And she'd say, what the hell are we talking about? You're 94, you can't even walk. What sort of fun are we going to have? You know? So, and that's the kind of thing, you know. It isn't that they're dirty old man, that is what the disease does, okay? Vision. People with dementia are also prone to falling, because it affects people's vision, so they cannot get the sense of depth of field. So be aware. If someone's got dementia, they are more likely to fall, although potentially. Number 7, dementia can also affect people's what? Perception. It's perception. And again, as I said about falling, things like black mats. Now you think about most supermarkets. You go to the front, there's a big black mat, right? Now a black mat to someone with dementia can look like a hole, a big hole. So imagine you've taken me shopping, we've gone to Sainsbury's, we get to the front door, there's a black mat. What am I likely to do when we get... I'll probably stop, right? Yeah. And if I stop and you don't know what I'm thinking, what might you do? Yeah, poor me. Guess what? We're going to have a fight. Especially if I've got frontal temporal and I've got an angry temper and you start pulling me around. Right, so yes, so always for people with dementia, if they're unhappy, change the subject. So, you know, if you took someone walking and they stopped for whatever reason, all you have to say is, okay, we'll come back another time, or let's go a different way. Don't try and force them, because imagine if there's a real hole and I try to force you across a real hole, you're going to whack me one, aren't you? So that's what we're going through. So always change the subject with them. You may be able to bring me back in a few minutes' time and I'll be fine, okay? Another thing to notice, especially on these kind of lights, fortunately these tiles aren't too shiny, but shiny floors can cause a problem to people with dementia because it can look like water. So again, imagine you've taken me, because supermarkets have those bright lights, they have tile floors. If you've taken me walking or shopping into Sainsbury's and I suddenly think there's water in the room, or if I said to you, right, you know, in 3 seconds' time, the floor's going to turn to water, right? If you're still in the room, you're going to drown. You've got 2 seconds. Quick, what are you going to do? You're going to run. And that's what somebody with dementia is going to do. They ain't going to hang around and say, you know, this is my thought process, and they're out the door, right? And again, if you do not know what I'm thinking, what might you do? And as I head off to that door, you're going to pull me back. And again, we're going to have some conflict, right? And imagine if you do pull me back in the supermarket and I'm put for having a fight with you, what do you think all these people are going to think of you? Yeah. And they might think you're abusing me, and you know, and the pressure levels, the stress levels go through the roof. Okay, so just be aware of that, as I say. Bright lights, black mats. In fact, some of our clients, because you're not allowed to lock people in with dementia, it's against the law. And people say, well, mum and dad go wandering at night. Can you lock the door? No, we can't. Against the law. Because what happens if there's a fire? Fire brigade can't get in, they can't get out. Doesn't end well. So what you can do is you can put a black mat in front of the door. So when they get there, oh dear, they want to cross that. Go and sit down on the sofa. And another technique is some of our clients use is they put a mirror on the front door. Because quite often people with dementia don't know what they look like. They've forgotten how they look. So of course when they come up to that door and they see that, oh, who's that person? Don't know, better go and sit down. And that's how you keep them in. So, just a little technique. Yeah, so it can affect people's perception. There's one other thing. And also just bear in mind, very patterned things can cause problems. We had a lady and she had one of those Axminster carpets, one of those swirly carpets. And I walked in to visit her and she went, Tony, can you move that snake in the corner? I'm sitting there going, snake, what the hell is she talking about? But it was the pattern, it confused her. And fortunately, the carer knew what that was going on. She got up and she went, you know what? Come on, snake, get out. Come on. She opened the door, she said, get out, slammed the door, sat down. They carried on. Brilliant. I thought, fantastic. Because what the carer did, she validated the lady's feelings. She didn't laugh at her and say, what the hell's wrong with you? She said, you know what? I see you have a problem. I'm going to help you. I'm not going to laugh at you and get rid of it. And they carried on and had a lovely exchange. 10 minutes later, the daughter came in and the same thing. She went, Sil, can you move that snake? This time, the daughter didn't play the game. She went, what are you talking about? You know there's no snake. How many times have we had da. And then the two women were arguing, both started crying, and the daughter said, that's it, I'm off. Can't stand this. Walked out, slammed the door. Now, had she done what the carer had done and just accepted the situation, she would have had a nice afternoon with her mum. Instead, she tried to change her mum's reality. Ain't going to happen. Big argument. Relationship damaged. Yeah. One of my friends here, he rang me up and he said, you know what? My father-in-law's moved in. And he said the place is chaos. He said he's got dementia and he's got all of us arguing. He said he's a right cantankerous old bastard. And now the whole household is up in arms. And I said, you can't change it. He's got dementia, right? You're going to have to change it, accept his reality. And he rang me back 3 days later. He said, you know what? Best bit of advice you ever gave me. He said, he's still a cantankerous old bastard, but I don't argue with him anymore, and now it's fine. Yeah? And that's the way we do it. We go with them, okay? Don't try and change their reality. Right, so, and one of the things about, and one thing I did miss about losing your memory, on skills, the ability to use hands and fingers and all the rest. We have quite often people with dementia, they lose the ability to use knives and forks, right? And I've seen it so many times, the families say, come on, you know how to use a knife and fork. And they can say, they insist, and I say, look, there's no point, they can't, right? Now, people with dementia have low self-esteem and low self-worth, right? They know things aren't right. Don't give them a task that they're going to fail at. Because all you're going to do is going to reinforce that sense of negativity, the sense that they're worthless. What you need to do is give them tasks that they are going to succeed at and have a positive outcome from. So if they are struggling with using a knife and fork, that's fine. You say, no more knife and fork. I'm going to chop the food up. It's finger food. Help yourself, right? Because then you're giving them back control. You're giving them back dignity, yeah? And they can now think, you know, okay, I can do this. I'm not useless, okay? So it's a small thing. Quite often I say to people, you'll notice people with dementia, quite often they always say no. Do you want something to eat? No. Thirsty? No. Now, what it actually means is that because the brain is damaged, they may not necessarily know what you're asking them. And it goes back to looking stupid. If I don't know what you're asking me, I don't want to look stupid in front of you. You've asked me a question, don't know what it means, no, right? And that's going to be my standard response. Now that can cause a real problem, especially when it comes to hydration and food, because people just keep saying no and they're starving. So I always say, and our carers are all trained, that if the client says, you know they haven't eaten, and you say, do you want to eat? And they say no, just make the food and put it there. Don't ask them, because if you ask them, do you want it? They'll say no. So just say, I made this, I'll leave it there. Because what will happen is the sight of the food and the smell, so long as it smells nice, we'll work on them. And if they're hungry, they will eat it, right? And I had a chap who said he's not hungry. 4 courses later, where's the next one? Oh, you're hungry. I'm not hungry. Yeah, you see? Same with water. Leave the water or whatever it is there next to them. Do you want this? No, fine. I'll leave that there. If they're thirsty, they will have it. Because otherwise what could happen is, and Kerry's often going, they say, oh, he said he wasn't hungry. He ain't eaten for 2 days. So if you keep going into accepting this, you're going to starve him. Right, and the person's not going to eat. So I say, if you're not in doubt, just leave it there. It's better to throw the food away than they starve to death. Right, so just leave the food and the drink there, and let it, I say the sight and the smell will do the job. Right, so we've done perception. Number 8, people with dementia can still do what effectively? Live. Anybody get anything else? Communicate. It's actually communicate. Right, I've got 5 minutes. I'm going to rush through this. Communicate. It's communicate, because people, they can still communicate, but because to make life easier, speak slowly to them. Always never cover your mouth, because they're quite often lip reading. Okay, look them directly in the eye, because they're looking at you and your body for clues. Okay, speak slowly, and quite often body language nice and open, and use aids. You know, if I say to you, do you want a cup of tea? You might think, oh, what's the cup of tea? I don't know. Now our carers will, some clients, they've got a picture of a cup of tea, so they'll just hold it up. Do you want one of these? Yeah. Or do you want one of these? Want a cup of tea? No. Do you want one of these? Yeah, there you go. Simple instructions. So these are some tools and techniques. I'm going to be rushed, so I'm going to give you the answers to the others, because number 9 was 1 in 14 people has dementia. Number 10 is it possible to do what with dementia? I'll do this one because it's important. What do we get for that? Live well. Yeah. Number 11, there is what to the person living with dementia? More. Now this is important because there was a lady down the road in Mitcham, and she was 85, but she couldn't speak. They put her in a nursing home. She was fine, but she couldn't speak. But what she kept doing was this. And at first people laughed and they got really fed up, and they asked her to stop, and all she did was louder. One day, the great niece came down, and the warden said, why does your aunt keep doing this? Because it's really upsetting the other residents, especially at night, because it goes through the whole building. And she said, I don't know. Then she thought, but during the war, Auntie worked in Bletchley Park. And he went, Bletchley Park? So he thought, yeah, someone's nodding there. So what do you think that might have been? Yeah. Code, yeah, that's right, Morse code. And he thought it must be Morse code. So he rang up the Mitcham Scouts, 33rd Mitcham. Scout said, can you send a scout down, please? Because scouts, so we all taught how to do Morse code. And little Jimmy rocks up and said, hello, Mrs. So-and-so, how are you? I've heard an awful lot about you. He said, I'm really pleased to meet you, all in Morse code. And the first thing she tapped back was, thank you. Because she'd had 4 years of being shouted at, shut up, be quiet, stop tapping. She couldn't talk. The only way she knew how to communicate was Morse code. Now the point of the story is there is more to the person, because that warden thought, you know what? This is maybe Morse code, and he was actually spot on. So do not look at the dementia. Look at the person. We've all got pasts, we've all got histories. Talk to people about, what you'll find is people will talk about the old times. People often say to me, you know, Mum and Dad can't have dementia because they can remember their childhood in ultimate detail. They can, but the reason that happens is because the memory, imagine your memory starts here and goes to the bottom. The most recent ones are here, and the oldest one. It starts with the most recent ones. So I probably will not be able to remember what I did yesterday, but dementia hasn't attacked the memories at the bottom yet. That's why people remember all their childhood memories and all their early life memories, which is why if you're talking to people, don't say to them, what did you do yesterday? Because you're going to, again, negatively reinforce the fact they can't remember. I'm going to feel pretty bad now because I feel pretty stupid. You're asking me something so simple I can't answer. What did you do when you were a kid? Oh, I can remember that, because that will suddenly bring them alive, right? Because those memories are all intact. So that's where we go. We go to the happy place, right? Because they then can navigate those memories. They now again feel in control. It's the good times. They can converse with you. So as I say, we always say, you know, look at the photographs, talk about the past. That is what's going to help the people. Don't set them tasks, you know, insist that I want to talk to you about what happened yesterday. Okay, so look at the person. We've all got past. Let's talk about what we did in the past. And finally, number 12 was about turning understanding into action. Right, so I have run out of time. So any questions?
Yes, I'd like to ask, you know what you said about something body, and then you got
Lewy
the
body.
delusions.
Yes,
And,
Lewy body dementia.
yeah. How do you spell that?
Lewy is Lewy. Yes.
Thank you.
Mm.
Can I just ask you something? See, I've not done all of this and I'm still holding because I'm not feeling well.
Yeah.
I didn't understand. I understand vascular dementia.
Yeah.
Alzheimer's, what causes it?
Well, no one knows what all we know is that the brain gets coated in proteins. Why they don't know yet. And obviously there's a lot of research going into that, and hopefully they'll get a solution in the not too distant future. Any other questions before I depart?
What was the question?
Action, turning understanding into action. Sorry, I'll take that one more, last one.
Does COVID, having had COVID recently, does that affect dementia?
COVID. The honest answer is I don't know, and I guess what can happen is the symptoms can get worse. Now, there are a lot of things that people with dementia have certain symptoms, right? Symptoms can get worse through stress. For example, if you remember the acronym PINCH, what can make the symptoms worse? It's not making the dementia worse, but it might make them appear to be something, or the dementia worse. Pain. If someone's in pain, we had a guy who kept saying, I want to go home, right? I want to go home. He was at home. The carer knew there was something wrong, because that wandering or repetitive behaviour is usually a sign that something's wrong. They're emotionally distressed. In this guy's case, his dentures didn't fit. He kept saying, I want to go home. She said, I think it's his teeth. Took him to the dentist. It was cracked on the bridge. They fixed it, put it back in. He didn't want to go home anymore. He was fine. He was in pain. Right, so pain can cause symptoms, or your symptoms make symptoms worse. Lack of nutrition, being hungry. Infection, quite commonly UTIs. If someone gets a UTI, it can really send you over the edge, and it looks like the dementia is really bad. It isn't the dementia, it's the infection. The urinary tract infection for UTI. Constipation. If people haven't been to the toilet and they need to go to the loo, their symptoms can get worse. And you might think, oh my God, the dementia's got worse. It's not. They're constipated. Okay. So back to your question about COVID, possibly, because there are a number of things that affect the symptoms. But it's not that the dementia's got worse, it's the symptoms that have got worse. Treat the problem, and the person's behaviour will return back to normal. Right, I better stop there, because I can see Susie look at me and go, get off! Right, so thank you for your time. Thank you.
Absolutely brilliant.
Oh, brilliant. I hope you enjoyed it.
Well,
Thank you.
on behalf of all of us, thank you very much. It's just a little token.
Oh, thank you. Thank you, everybody.
Thank you very much.
Cheers. I haven't actually, but yeah. Thanks.
We're going to have a little break now. Can I ask you just to turn your phones off if you've got them, please, just so we don't get interrupted. Right, is it off?
We'll just have a 2-minute break, and then we're back. And then after this next session, there's lunch, and you're encouraged to go and have a chat to the people at the various tables of information, South London Cares, Black Prince Trust, etc. So enjoy the next talk on diabetes. It's basically a question.
Yes, it's going to be actually your questions. So that I think most of us who have ever had anything to do with diabetes probably know that they understand their own symptoms, but there may be more to know. So do ask the questions. Yeah.
So rather than a presentation,
yeah.
So we'll go and get our next speaker, and we can get started on that session.
Okay. Yeah, please, just have a coffee or a tea or something and a biscuit or something like that. Let's break. There's a lady outside that's part of your practice. Never heard of you. So what paper? My practice. Yeah, because I'm sitting here. Yeah, so she's on. Did you sign in with someone? You've been to the practice. Okay. So I said to you how you need to contact my friend. Now you're here, so I'm going to put you two together. Come here for a minute. Yeah.
She's there, and she's always looking for volunteers. Because we have one there also, Western. We're there all the time. We've got the new one with the picture house. Literally across the road. Yeah, so do I. Yeah, so do I. Picture house. But the literally opposite is the old blood, and Kevin runs a session there as well. Again, she manages the Kemi, I'm just down at Clyde's surgery. What day do you run? Is it Wednesday for something like that? Oh, that's years ago. At 2:30. 2 to 4, and then the Rose Cafe. When you see some of the ones, I don't want to be in this hall. So I just with some people now. Oh, well, great, thanks. I'm sorry. Bye. I'm very sorry. 2 to 4 Wednesdays. Thank you very much. That's it. Thanks for the best. Thank you. Wednesday she runs the something. I know. Oh, right. Oh, yeah. Well, there's also Thursday. She started off breathing. So I will do them because I was asked to do it. I enjoyed doing it. That's what I know about this is very Oh, I'm glad you enjoyed it.
Oh no, I'm looking at the right one, which is definitely but
very, very good at different
Right, we're about to start in the next couple of minutes. So think of your questions about diabetes, because we want lots and lots of questions.
Hi.
So if someone says to you, I don't know, do you get your insulin or you just say, you get your insulin or 5?
No problem. He did say that to me, which I think is really good. Just to, I think when I was struggling with the mic, he's like, let me give her a brief quickly. Because I have never put a mic on, so it's exciting, yes.
And then if there's anything she says that's saying in the chat on like the YouTube channel, I'll ask the question.
Brilliant.
For you, but we don't have any in advance.
That's okay. I do a bit of teaching, so I kind of get asked questions a bit, and I've done things in churches with groups too.
Sure, you'll be fine.
So.
I think it's just the fact that some of the voices won't be picked up.
No, of course. I hope, yeah.
So that's all I was worried about.
Hello. Hi.
Are you going to be, I know your face, I'm going to be here.
I work in the Lambeth diabetes team, so so I'm not sure, and I do talks sometimes. I've done a few talks, and I used to work at the hospital, so a lot of people. I'm not sure. I've had different places, so sometimes.
I used to work in a hospital, I'm retired now.
Okay. Okay.
District nurse.
Wow.
I'll retire at 65 because I think it was time for me to start looking after myself.
Definitely. You do spend so much time looking after others that you need to get a little bit of. I imagine.
They used to look after me when it's winter.
Hi, Susie.
You're ready to rumble.
Hello again, everybody. Welcome to the next session. And today, at the moment, we've got. Hello. We've got Ilsa here, and she works for the Lambeth Intermediate Diabetes Care Team. And she's not going to actually give a presentation, but she would like to hear from you about your.
Hi. It was lovely being here. I'm so glad that you all came here today. I'm working within the Lambeth Diabetes Intermediate Care Team, and we support all the GPs in Lambeth. So when the doctors are having a patient on multiple medications or possibly needing to start an injectable therapy, they refer to our team. My experience is I used to work in the hospital, so I did acute care at St. Thomas's and Guy's, and now I'm working in the community, and I've been a nurse for about 8 to 9 years in Lambeth, and I understand that I think it is really difficult navigating around diabetes because there are lots of different questions and there's lots of things for people to know, and because of it being a chronic condition, it doesn't really go away. So I understand that sometimes it can be difficult in coping with it, because it's not something, you know, that you can treat and then it can get cured. But I'm here to try and give you support and answer questions or just anything about diabetes. I tend to look after people with type 2 diabetes, which is different than people with type 1 diabetes. But if you've got questions or wanting to know the difference between the two, or about your medications, about what you can do to help control your diabetes, anything that you can think that or questions you just never got a chance to ask, you know,
So the difference between type 1 and type 2 is interesting, and also like I'm pre-diabetic, so I want to know what I need to do. It's very hard to always understand what you need to be doing other than obvious things like lose weight and eat more healthily, but any tips or advice would be helpful.
Brilliant. I think that's a really good place to start. Can I just get your name? Sorry. Alan, thank you for the question, Alan. So what Alan has asked, which a lot of people get confused by, is what is the difference between type 1 and type 2 diabetes? And when somebody has type 1 diabetes, it means that their body's not producing any insulin. So somebody with type 1 diabetes is going to need, from diagnosis, will need insulin. And normally they're using like 4 or 5 injections or insulin a day. Versus with type 2 diabetes, you can have type 2 diabetes and be on insulin. It just means your body's producing insulin, but it's just not enough insulin. So usually for the pathway for people who have type 2 diabetes is that they usually start on tablets, and then they may have a first set of tablets, and they'll go to like 2 sets of tablets or 3 sets of tablets, and insulin usually comes when the tablets are not working as well, and their body's just not producing enough insulin. So because sometimes people think because they're on insulin that they're no longer type 2 diabetes, but if you're diagnosed with type 2 diabetes, you will always have type 2 diabetes. So that's the difference, is with type 1, the body's not producing any insulin, versus with type 2, you are producing insulin, but just not enough. Okay? And what I was going to add, I don't know if this is helpful or not, but looking at this, I just was looking at the statistics because it's always changing all the time, but there are about 4.9 million people living with type 2 diabetes in the UK, and that represents about 90% of the population. So most people do have type 2 diabetes, and usually about 10% of the population is with type 1, and type 1's usually, people who are diagnosed with type 1 is normally children or young adults. It can happen in older age, but it's very rare. And Alan, you asked me, I'm trying to remember all the questions, because you asked... Okay, so before I even go on to pre-diabetes, I think it might be helpful to clarify how do we get diagnosed with diabetes? Does everybody, because normally you go to the GP and they do a blood test. So when we're looking at doing a blood test for people with type 2 diabetes, not for type 1, they do a blood test, and what they're looking at is something called HbA1c. I wish I had a board, I feel like a teacher. So HB stands for hemoglobin, and A1c is sugar. So when you eat anything, the sugar gets attached to your red blood cells, and the red blood cells last for approximately 2 to 3 months. So when we do the blood test, where the GP does the blood test, it's able to see how much circulating glucose is in your body for the last 2 to 3 months. So it gives us an average of what's happening. So it's not like when they take a finger prick of your finger and they check, sometimes they just they prick your finger and you get a reading. That tells us what is happening, like a snapshot right at the exact moment. Versus when you go in for the venous blood test, when they take it from the arm, that is giving us an average over 2 to 3 months. So when we're diagnosing whether you have pre-diabetes or diabetes, we tend to do the venous blood test. Unless they do a finger prick and it's very high, then obviously we know that you have it. But usually it's to do a venous blood test. And typically they do 2 to diagnose you. When we're looking at the HbA1c, I'm not sure anybody knows what the values are. That's I like when people help, because I want it to be interactive. So Alan is right. So to have a diagnosis of diabetes, the HbA1c must be 48 millimole over mole, or sometimes some people say percentages, which is 6.5%. But we tend to use the 48 more, because the rest of the world does it millimole over millimole. So pre-diabetes is usually when you're 42 to 47 is for pre-diabetes. Just so that everybody understands. And Alan, and a lot of people, it's nice when you're in a situation that you get diagnosed and it's pre-diabetes, in the sense that you have some time to work at things. And a lot of, I know it's hard, a lot of it is to do with lifestyle. And with diabetes, it's the older you get, there are lots of risk factors with developing type 2 diabetes. And part of it is genetics. Part of it is family history. And if you're a woman who've had gestational diabetes, tend to be more prone also getting diabetes earlier. But family history is a very strong one, and genetics too. These are things that we have no control over. But the things, I guess, when you do see somebody, or the GPs, or talking to people, they do kind of focus on the things that you can change, and that tends to be lifestyle. So, it's a harder one to do, I know, but it is really looking at how much we're eating, because we all tend to overeat a little bit. I know I do myself. So, and when we're looking at diabetes, what I try to focus on is doing things you enjoy. And I don't mind vegetables, but it is when you're thinking about a plate of food, having food that you enjoy eating, because there's no point in changing your diet or making changes when you're not going to sustain it. So even if it's a small change, because sometimes we get so scared and we want to make we want to make a drastic change, and it's so difficult to make change, I think personally. So I think sometimes small changes are better, and then we can gradually keep making small changes over time, and that will help us with our overall goal. Because if we try to change too much too quickly, a lot of times we fail in what we're doing, and that just makes us feel a bit more depressed, or just you don't feel like tackling or wanting to. So I do think small goals are better, and even if it's just doing like 10 minutes of exercise every other day, or walking, or find something that you enjoy doing, if it's dancing, or or even just going to a park with friends. And we do find if you're doing an activity with somebody or planning it with somebody, it makes it easier for you to continue doing it. And I'm sure you all could give me advice about food, but a lot of what we say is trying not to have too many carbohydrates or too much sugary foods or desserts, that to try and cut down. And the main big culprit when I was in hospital, if people is trying to cut out juices. A glass of juice has about 6 to 12 cubes of sugar, depending. So juice, any type of juice, even if it's freshly squeezed juice, it has a lot of sugar, and it's much better to have the actual fruit because you're getting the fiber. I think fiber is really important because it helps to keep you feel full and helps the blood glucose levels stay at a steady level. Does that help? Sorry.
How much fruit are we supposed to have?
That's a really good question. Can I ask? I love finding out people's names when I'm talking. Patricia. So Patricia's asked, how much fruit should we have a day? Does anybody want to give a guess, or?
5 portions a day?
That's what's on the TV, and I know where you came up. When they say
Fruit and vegetable, yeah?
that's correct, but actually that's correct. So the guidance is 5 pieces of fruit or vegetable a day. But you can have as much vegetables as you want. Hi, sorry. I just want to thank you. See, when it comes to fruit, we say not to have more than 3 portions a day. So it's a little bit different. I know it says 5 of fruit and vegetables, but with vegetables, we encourage you to have as much vegetables as you want. But when it's with fruit, because fruit has sucrose or fructose or sugar in it, that it is to do with 3 portions of fruit. And a portion of fruit is what you can hold in your hand. So it's an apple, or an orange, or a piece of pear. If you're having a mango, which I love mangoes, it tends to be, I know it's unrealistic, either getting a small mango or cutting it in half. So if you're having even like watermelon, it's about having slices. So it's just what you can hold in your hand. It gives you an estimate of, and everybody has a different, and unfortunately, I have a small hand, so I can't really have too much. But anybody who has a bigger hand, you're allowed to have a little bit. So that's why we say a hand size, because it kind of, depending on your size, it gives you a better estimate of how much you can have. And sometimes when I'm doing clinics, patients will come and say, well, I'm having my 3 portions of fruit a day. But what they tend to do, which I can understand too, is they'll have it all at one time. So they'll have it, you know, they'll have like a big fruit salad. And
that's what I tend to do. I have every fruit. So how much do I have?
so what what our dietitians recommend, because I love doing that, I can understand that. What they recommend is that not to have it all at one time, because it will cause, because it will cause a spike with your blood sugars. So if you have a small bowl, even if it's just a small bowl, just have it like, I have like this really small bowl, just if you're liking 2 grapes, you know, you could do a few segments of orange, if you like having a mix, but it's a fruit of one of those things that I love too. And I know it's difficult, but it is really about trying to have less. So even whatever you're doing, try and have a little bit less. Yes.
Steve.
Hi, Steve.
How would it be to eat through the day 6 satsumas, 6 to 8 satsumas, and 2 or 3 bananas?
It was me.
Okay. Well, unfortunately, did everybody hear the question? So I'm going to repeat it just because hopefully my voice is nice and loud and clear, that everybody can hear me. It's Steve. Steve had a really good question in response to his wife. He was, and maybe anyone, Christine, and he was wondering, well, what, and you could probably give me a response today or help me. He was saying that Christine likes to have 6 satsumas, minimum, 2 bananas, and I think there was one more.
And probably other things.
Okay, so what?
Wouldn't be bad because it's fruit, and Christine says, my mum always told me to have lots of fruit in case I was hungry. This is the thing. You just told me that over 2 might be too high on the sugar level.
It is. I mean, if you have pre-diabetes or diabetes, and I'll be really personal with you guys. Both my grandparents and my father and almost all my aunts and uncles have diabetes. For me, I tend to be careful just because I know that I'm at an increased risk of developing type 2. And I'm from the Caribbean. And when you're I'm from Trinidad, and a lot of Caribbean people are more prone to have diabetes, you know, and you're usually getting it at a younger age. So even though I don't technically have to yet, I try to be careful not. I love fruit, and it does have lots of vitamins and minerals, but for most people, it does cause, it's too much of a good thing. It does, although it's good for you, it does cause spikes so if you're on medication, for most people, it will cause them to it will cause your sugars to spike a little bit.
And what would be the outcome if you get diabetes? What is it as a disease? I was classed as a type 2 a few years ago, and I changed my diet, and then they said, oh, you're nearly pre-diabetic. Yeah. But they didn't say what diabetes was.
I think Stephen has a really good question, because a lot of times you go to see your doctor. Did everybody hear that question? Sorry. Yes? So he kind of, and maybe if some of you know the answer, because I like when it's a little bit more interactive if anybody's brave. He says that he was diagnosed with type 2 diabetes, and obviously he had advice about diet, and he did really well, that it's kind of the blood sugars actually went to almost pre-diabetes now because of the changes he did with lifestyle.
That was after. I mean, maybe I'm relapsed and I'm just as bad because I eat a lot of biscuits and cake. I love it. And I just haven't been tested lately, but I just wonder what the long term. You know, if you've got, for example, leprosy, your fingers will fall off. Okay. I know the results of leprosy. What's the results of diabetes?
Okay, this is a little bit more of a heavier topic. He wants to kind of know what can you expect to happen, or what can happen when you get diagnosed with type 2 with diabetes. And from all the research, because they've done lots of really big studies, and there are lots of factors. So it tends to be when you're diagnosed earlier, with poor control, you're more at risk of complications. So the reason, and it's not just that, it's a metabolic disease. So when we're thinking of diabetes, we're not looking at diabetes as separate. Usually for a lot of people when they get diagnosed with diabetes, they may have high blood pressure. They may also be, their cholesterol level may be a little bit high. So if you're looking at, it's very rare that I see somebody who who may not be on tablets for their blood pressure or for cholesterol too. So because of it's they're all working together. So when your blood levels are high, glucose levels are high, it can damage your blood vessels. And that's on a very simple, just to make everything really as simple as I can. So and it makes it really tricky because a lot of patients, even when they're, if you've got cancer, if you have you're normally feeling well. And what's dangerous about diabetes is that you can have really high blood sugars sometimes and you feel fine and you don't know. And I think that's where it's a bit scary because you have lots of people walking around and it's really hard to make changes if it doesn't affect your health. And it's like, well, I feel, symptoms, yeah. And not everybody, some people, even with really high blood sugars, I'm like, are you not going to the toilet more often? Or I kind of talk, and not everybody has the same threshold for getting symptoms. But unfortunately, when the levels are raised or elevated, it does damage your blood vessels, and that's your large vessels and your small vessels. So we're looking at the heart, the kidneys, your eyes. It's making the blood stickier. There's more risk of the blood clotting. There's so many things that are happening when you have raised blood sugars, but ultimately it can lead to damage of your organs, and that's what we want to prevent. And we should, everybody here, just to I will answer more questions, I'll talk about symptoms too, but it's really important that we're going to the GP regularly, at least once a year, to check what's happening with your diabetes. That should be something that you should be going to get your blood test done at least once a year. And if you're starting to feel unwell or you're having more symptoms, I'm sure the doctor will arrange for you to get another test to see if something is changing, because obviously we don't want to wait 6 months if something is happening, or if your blood sugars. But normally for people with what's your name again? I'm going to talk about Claudette. That's a pretty name. So Claudette asked about symptoms. Does anybody know what the symptoms are if you have type 2 diabetes? Yeah, that's good. We're going to the toilet more often because dry mouth, that's correct. And you ever think about why you're getting these symptoms? Why is that happening? Because as we know, it's toxic when your body has too much sugar. And even though you may be feeling well or may not have the same level of symptoms, what your body does is it tries to get rid of the extra glucose. And that's why you're going to the toilet more often, because the body knows it's not good. So it is trying its hardest to get rid of as much glucose as you can, so it's excreting it through the kidneys, and you're passing extra glucose in the urine. And when you're passing extra glucose through the urine, because you're passing out more fluid, you start to get dehydrated. And that's why a lot of people who, if the blood sugars are high, they may tell you they're feeling thirsty and wanting to drink more. Is because they're getting dehydrated, because they're passing out more and more sugar because they're going to the toilet more often. And when your blood glucose levels are high, bugs love glucose. It's like food. So a lot of patients, if somebody's coming to their doctor and they're realizing that their skin is really dry, or they're getting lots of infections like urinary tract infections, or even any type of infections, it can be brought on, especially urinary tract infections, because the blood sugars are high. So if you're getting infections or dry skin, going to the toilet more often, feeling tired because you need glucose for energy. So I would never sit here and tell you to cut out carbohydrates or cut out fruit, because you need some fruit for energy. So, but because your body is not able to use the glucose properly, because when you get diagnosed with diabetes, usually there are things happening a few years before you get diagnosed in the pre-diabetes stage. What can happen if you've got some weight around your tummy? we call that insulin resistance, and that means the insulin that you have on board doesn't work as well, you know. And when people I get really, I know that most people with type 2 diabetes, they tend to have a little excess weight around the stomach, but lots of people with type 2 diabetes are really slim. So it has to do with age. There are lots of different factors that interplay, and usually when somebody is slimmer, it's to do that their body's just producing less insulin. It's not to do about insulin resistance. So they're different, you know, and there are different types of diabetes too. But yes, so as we talked about symptoms, so if you are getting any symptoms where you feel like you are going to if you are diagnosed with type 2 diabetes and you do find that you're feeling really tired because, you know, or you go to the toilet more often, you're feeling really thirsty, getting infections, get the doctor to recheck your diabetes, because it may be that the tablet that you are on may not be working well enough, and they may need to add on another tablet, or maybe go through things that you might possibly can change with your diet, or maybe starting to do a little bit more exercise, because diet and exercise has a profound effect on helping control the diabetes.
And someone online has asked about how does honey instead of sugar affect diabetes?
That's a good question. So somebody's just asked about how does honey versus sugar affect the diabetes. Does anybody want to hazard a guess? What do you think? Honey is any better than sugar?
Honey, I would say honey is a lot better than sugar, yes.
Natural honey. A lot of people would say that, but unfortunately, it has the same effect. Because if you have 3 teaspoons of honey or 3 teaspoons of sugar, it gets converted into glucose. So any type of sugar, whether it's natural sugar or whether it's actually processed sugar, it's still going to be converted into glucose and it will cause your blood sugars to spike. And a lot of people get that. You know, people think by switching over from sugar to honey that it's going to make a positive change, but unfortunately it's going to have the same impact when you digest. And a lot of patients, when they do have low sugars or hypos, sometimes when some people can have low sugars, we actually recommend honey because it brings up the sugars very quickly.
I've got a question on type 1. Do you want to?
Do you mind if we just answer this one online and then I could come to you next? Thank you so much. Yes.
So this person has only recently been diagnosed with type 1 diabetes, and at the moment they're struggling in the morning, having low sugars and hypos through the night. Do you have any advice?
That's a really good question. People who, individuals with type 1 diabetes, from my experience, they tend, because of how insulin works, insulin helps to bring down the blood sugars very quickly, that they're more at risk or more prone to having low sugars. If the trend or the pattern is that they are having low sugars overnight or hypos overnight, it normally indicates that they're having too much insulin at night time, because lots of, without knowing too much, a lot of people are either on a pump. I'm not sure if he's on a pump or if he's on something called a basal plus, which he's on a bit of long-acting insulin twice a day, and then sometimes fast-acting insulin with food. But if anybody with type 1 diabetes should be under the hospital diabetes team, and there are inpatient specialist nurses who can help to navigate, and sometimes they're on the Freestyle Libre where they can scan their blood sugars. So he's obviously on too much insulin overnight. That's causing the blood sugars to dip, and that's not good to have. Although I get as concerned with very high blood sugars, I am just as worried as low sugars. They're just as dangerous. So we really try to avoid high and low sugars. So he should have been referred to the hospital diabetes team, and I would definitely get in contact with one of the specialist nurses, because they should be giving him advice or support, because it's worrying to hear that he's having hypos, and usually it's indicating that he's having too much insulin overnight. If you could ask him if there's anything, if that helped, if there's any other questions. I'm sorry. And then I'll come to you, and then I'll come to you. Just because I just wanted to see if that helped answer his question. Sorry.
No, that's fine. It's on a slight delay, I think.
That's okay. Well, I'll answer the next question if he's got anything, yeah, but it's definitely, yes.
Hello.
Hi.
My name is Mike.
Hi, Mike.
From the bowel surgery.
Okay.
I'm not a diabetic, and there's no family history, but like a lot of people, I enjoy sweet things, and I was going to talk to you about certain things that I would like to avoid that I may get diabetes. Now, we've touched on fruit,
yeah,
and I was going to ask you about that, and a particular fruit. Steve, I believe at the front, talked about 6 satsumas and 2 bananas a day.
Yeah.
Am I right in thinking that 1 banana can contain up to 6 spoonfuls of sugar?
Bananas are quite high in sugar, especially if the bananas are ripe.
So surely that's not a good idea.
You're completely...
That's why I asked the question.
No, it's not. It really...
I don't think it's a good idea. So my question is, what kind of... And we talked about the fruits that we could eat. Is there a good way? Is there a good idea to make a smoothie out of fruits?
A lot. I see a lot of patients who start juicing or having smoothies, and that kind of brings them from pre-diabetes to diabetes, because it's putting a lot of. Because if you're doing that, a lot of people have gone onto these smoothies where they've cut out meat and done that, and it really does. A lot of pre-diabetes become diabetes because of the amount of sugar in fruit.
And you talked about not eating too many fruits at once.
Exactly.
So if I make a smoothie and have half a glass at one sitting and half a glass later on in the day, is that a good idea?
The dietitians would say it's better to just have the actual fruit. I mean, you can possibly do it, but because normally with fruity, because with smoothies, it is having a lot of fruit. If it is something you enjoy, obviously having less is better, but I tend to try to get people not to have smoothies, or even get the innocent smoothies, because
you're saying it's better to eat fruit.
It's much better to eat the fruit.
Rather than make a smoothie. Okay.
Exactly.
Another question is, I'm very fond of dark chocolate.
Okay.
And if you took a bar of chocolate, how many pieces would you recommend a day one should eat?
Well, you're very lucky because you don't have diabetes. And dark chocolate is a bit better because you tend not to eat as much. Yeah. Like strong cheese. Yes. And I think having 1 or 2 or 3 pegs a day is fine. As you don't have diabetes, it's just about moderation. Yes. And not having a bar at a time. So it's just thinking about what you're eating. That sounds very reasonable to me. Yes. Yeah. And that.
Thank you.
My pleasure. I love that everybody's asking me all these questions. This is wonderful. What's the next question?
I'm Louise.
Hi, Louise.
I just wanted to, do you know prednisolone, how it affects, because that sent my blood sugar.
That's a brilliant. Louise asked a really good question. She's asked about a tablet, and I'm not sure everybody knows about this. There's a tablet called prednisolone. It's a steroids tablet. And I didn't mention that with one of the reasons, remember I talked about things that can cause your blood sugars to spike. We talked about, lifestyle. But also if you go in hospital and you're put on steroids, it's very, very common that any type of steroids, even though you need steroids, I'm not saying not to take it, but one of the side effects of having steroids is that it does cause your blood sugars to go really high. And we've had sometimes when we've had patients who had steroids, we need to start insulin because it does, especially depending on their dose, if you're on 20 or 30 milligrams. For lots of patients, especially if you have diabetes or even pre-diabetes, it will cause the sugars to spike. So normally when I was in the hospital, we were visiting patients, we always try to make sure that for patients who are put on big doses of steroids that they get a blood test done, and that the nurses in the wards check their blood sugars, because a lot of patients do need insulin, and it can put on. There are lots of things with steroids, but unfortunately sometimes you need it for whatever healthcare reasons. But that's a really good point. So if anybody who has type 2 diabetes, if they are put on steroids, it's really important that you go to your GP so they're aware, and that you are checking your blood glucose levels more regularly, because it can cause the sugars to spike and you can get really unwell. So that's a really, thank you, Louisa. So that just for general, I think we could all learn from each other. So I think all these questions are kind of highlighting things that you know or experiences that other people could learn from, which is really valuable. Thank you. And even asking about the fruits and stuff, I think you all had really good questions. And I know it's hard making changes, so even if you could cut down the 6 down to 4 and gradually, but it's just kind of monitoring. The whole thing is that if you do have diabetes, that you are going to see the GP and that it gets monitored. And if you start to feel unwell, that they are aware, because it's not really what you're taking, but it's about the control. We know that people who have better control, they have much better outcomes. And my role is I want to help patients with diabetes feel more confident in managing their diabetes, but and also have a good quality life. I don't want people to we're trying to avoid dialysis, we want you to have energy to be able to do all the things you want to do, go on holiday. So that was part of the reason why we're striving. It's not just for the sake of numbers, it's because about quality of life. It boils down to good quality of life and supporting everybody. Last thing, sorry, yes?
So just this woman online.
Yeah.
So she said that she had been referred, but they put her on 5 insulin shots a day, 2 long lasting and 3 with food.
Yes.
She's found it hard to get support as a new person being diagnosed, and so she wants to know if there's any good support groups out there for her. And when she was admitted to hospital originally, she was admitted with high sugars, so it's all quite confusing.
It is very confusing. With type 1s, it's a lot of managing different insulins. I definitely, whichever hospital, there should be a inpatient nurse to support her. There are forums on Diabetes UK, but I do think when it's managing insulin doses, you need a healthcare professional. So yes, it's good to do group support where they can give you tips. And she should be on, there is something called she should be on not the insulin with food, but the long-acting insulin that she's taking. That would, I'm not in front of her and I don't have all the numbers, and I don't think it's safe for me to do something virtually, but she could even just call her GP, because it does sound like she needs a little bit less of the long-acting insulin, because we just want to avoid, it's really getting blood sugars within a range, so they should have an optimal range for her, where she should be checking her blood sugars before food, and there should be levels. But Diabetes UK does have forums for type 1 diabetes, and maybe that might be a good place for her to start, but also get in contact with the hospital, because they're there to support the individual. And it is very confusing and complicated being on lots of different injections, and I do empathise, and hopefully that would help. Yeah. I'm going to wind. It was such a pleasure. I really enjoyed doing this talk. One last question. Yes?
Would it be better, like if when you're cooking rice, to strain the rice, and if you're cooking potatoes, would it be better to strain it to get the starches out?
They haven't done enough research, but what I do know with rice, I tend to, when I'm doing it, I think it's a little bit better, but there isn't enough strong research to say. Some papers have said yes, some have said no, to be honest. So when I'm looking at rice, what we tend to say is if you're having white rice, have basmati white rice, because it has a lot more fiber. So with white rice, basmati rice is really good. And obviously brown rice is better than white rice, because there's more fiber, so it helps your blood glucose level stay at a better level. And if you're looking at potatoes, try to have not more than 2 or 3 small potatoes or 1 large potato. It's really more about portion size.
Thank you.
Okay, thank you so much. Thank you.
Appreciated you coming along. You did absolutely brilliantly. On behalf of us all, a little token of our appreciation.
Thank you I thoroughly enjoyed it. Thank you so much.
Thank you very much indeed, and good luck to you.
Thank you.
Thank you very much.
Bye-bye, thank you.
I'd just like to say thank you again. I'd just like to say a few words about patient groups, if I can, because this is my last session this morning. I'll be handing over to Susie this afternoon. And I'd just like to ask, how many of you have heard that each practice has a patient? And how many of you have actually attended any meetings or had any contact?
The last one, I would say 1
Yes. Which practice are you? The Exchange, yes, they have quite an active patient group, don't they? For those of you who don't know, it's a liaison between, it's patient for patient. We're working on behalf of you guys, but we have the support of the practice. And we also have the ear and the information and all the other status things that goes with that from the practice. So, from my personal point of view, I get emails from patients with queries. It can be about uncomfortable chairs in the waiting room or long phone calls or whatever it is. And then I can then bring that up at the patient group meetings where we have the staff, the GPs, the practice managers, and we get the answers and we get things done and we get things changed. We've changed our phone message. We've changed our appointment system. The patients have done this. It's power to the patient. So I would advise all of you, if you really want to support the NHS in that way, then get involved with your patient group. We all have them, all the stress, all the practices. It's a contractual requirement from the government to have one. So that's what I say on that matter. Thank you very much indeed. Thank you. Enjoy the lunch is now served. Thank you.
And if we can be back here for 1:30, so it gives you a good half hour for lunch. So please go and enjoy yourself. Nobody's allowed to leave until all the food's been eaten.
Just told us about diabetes, yeah.
Remembering caution control, of course. But please do go and help yourself. And please be back here for 1:30 for the pain management session. Okay. Make sure you don't have all the bananas. Yeah. Yes, and then that's very end. That'd be lovely. Yes, if you're leaving, if you're only here for this morning, please do your evaluations now. That's all. Thank you, Alan. Good to see you. Yeah.